classification. It is tedious, it is complicated, and it is questionably useful. But exactly because of that, it is also a challenge to talk about the classification systems. So let me start with something that helps us understand as neurosurgeons what we're dealing with. It helps us communicate with our colleagues what we're dealing with, and ideally it will give us a path towards treatment. So the ideal classification system should have a clear definition of the pathology without ambiguity or freedom of interpretation. That means that if I say fracture is, for example, an A2 fracture in the AO classification, for example, that the neurosurgeon next to me or that the neurosurgeon in another hospital, we see it as such. This is the so-called inter-rater reliability. What is intra-rater reliability is if I see the same fracture twice in two different patients, that I will classify it as an A2 fracture in both cases. The ideal classification system should be void of subjective terms like moderate, severe, and the descriptions and the classifications, the taxonomy should be all-inclusive and mutually exclusive. What does that mean? It means that if I classify a fracture as an A2, then it cannot be anything else than an A2 under any other circumstance for this particular fracture. It should be straightforward, that is self-explanatory. It should be practicable, which means it should be simple enough for me to apply it into everyday practice. It should have characteristics that will help the taxonomy, that are easily discernible on imaging, in our cases, usually a CT scan. And the severity, although maybe not mentioned by the classification itself, should be inferred by the taxonomy, by the way the classification system is structured. A classification system should be reliable. The term reliability has to do with what we understand as accuracy and what we understand as error, which means that how accurate are we when we describe a certain fracture, and what are the margins of error. And the observation process and conversion process should be straightforward. The observation process goes without saying. I observe a CT scan, I see certain characteristics, but the conversion process is what makes or breaks a classification system. How do those characteristics that I see on CT translate into my mind? How easy is it for me to make this transition, this translation from a fracture in a CT scan into a class of a classification system? There are 21 applicable classification systems, and not all of them look at fractures in the same way. So I looked at each of those classification systems, and I tried to extrapolate what these classification systems were looking into. So all of them, of course, are looking into the type of injury. Most of them, they focus on the morphology. How is the fracture in the CT? 13 of them, most of them, look also on the injury mechanism, right? Is it a compression? Is it a distraction? What is the mechanism of injury? 17 of them, so the majority, have instability criteria integrated into them. And for most of them, for 15, it is the disruption of the posterior ligamentous complex alone that is the instability criterion. The posterior ligamentous complex gained attention after the 50s, especially with those classification systems, because they focused on the posterior ligamentous concept. And then there is also the Dennis concept, the three-column concept, as we all know it. 12 of those classification systems also focus on neurological status, and most of them provide some sort of guide for management of the fractures. Now, the first classification system to be somewhat similar to the ones that we routinely apply today, and I mention it here mostly for historical reasons, is the Boller thoracolumbar spine system, which is over half a century old. And it basically classifies thoracolumbar fractures into these three categories: the compression, flexion, destruction injuries, extension fractures, shear fractures, rotational and lateral flexion injuries, all of which you can see in the respective images. It is a classification system that takes into account both the morphology of the fracture, it's descriptive, but also the mechanism of injury, how it happened. But I think the similarities to modern classification systems end here, because it has no predictive validity and there are no reliability studies done. So we basically don't know how reliable the system is. Of all the four factors that a classification system ideally should take into account: anatomical, biomechanical, severity, and clinical, this one looks into, as I said, into the anatomical and the mechanism of injury, and which limits, so to say, its applicability and its practicality. The next step in the taxonomy of thoracolumbar fractures was somewhere in the 50s originally, but it got revised in 1983, and it is the Dennis classification for thoracolumbar fractures. And Dennis introduced the three-column system. It is a classification system that is well suited for the CT era, because the CT era allowed us to better describe, to better look into those fractures. So each column, the anterior, middle, and posterior column, is assigned a mechanism of failure. For example, I don't want to get too much into this. The anterior column sort of fails through compression, while the middle column can either fail through compression or destruction, and the posterior column almost invariably through destruction. Now, the anterior column is the anterior half of the disc and the vertebral body, the posterior column, the posterior half, and the PLL, and then whatever structures come rostrally to that are considered to be the posterior column. So classic knowledge has it that one column injury is stable, two column injury is probably unstable, and three-column injury is invariably unstable. The problem with the Dennis classification system is, of course, this arbitrary division of columns. I mean, from a biomechanical standpoint, it sort of does make sense, but exactly why the anterior column is a half or not 2/3 or 3/5 of the vertebral body is not well defined. It's rather arbitrary. And as the many recent classifications, we have four major types of injury. We have the compression, burst, the seatbelt, later named Schanz fracture, and the fracture dislocation. And this is the revised 1983 classification of Dennis fractures. You have in the upper left corner the compression fractures, and these have four subdivisions. So if it's only the superior plate, the inferior plate, or a split, or if it's just a vertebral body without involvement of the plates. And you have the burst fractures, which are classically compression fractures with both end plates involved, or with both the whole vertebral body involved, and so on and so forth. Another subtype, 5 subtypes here. Then we have the Schanz fractures, the seatbelt fracture, which is a transverse fracture one level through bone, owing to hyperflexion and destruction when the point of flexion is anteriorly of the spine. This is how you get a chance fracture to begin with. All right, and we have another 4 subdivisions. We have the transligamentous, transosseous fractures, and so on and so forth. I don't want to get too much into this. And then we have the fracture dislocations, where you have a misalignment of the sagittal or coronal planes, and complete disruption of the osteoligamentar complex of the spine. Now, the next classification is rather easy. It is intuitive. It covers both the anatomical, biomechanical, and severity aspects of describing a fracture. There are quite a few reliability studies, so we know that it is a reliable classification scheme. It does address stability, but the 1983 version of it is quite complicated with almost 20-something subdivisions, which can make the applicability of this a little hard. Now, in 1994, a German orthopedic surgeon, Mager, sort of suggested his own classification scheme. The types of fracture here are divided into 3 major categories: A, B, and C. A being the compression type. Again, here we have 3 subdivisions: the superior end plates, split, and burst. And then we have the destruction fracture, where the chance fractures or seatbelt fractures are included. Again, B1 if there's only ligamentous disruption, B2 intraosseous, and B3 a rupture of the disc itself. And then we have the torsion fracture, which are basically the type D fracture of the Dennis classification, with disruption of the sagittal or coronal plane of the spine. Now, again, it is a rather ripe classification system. There are reliability studies, so we know it's reliable. It does address stability, which is basically our main concern when we see such a fracture. The first thing we ask ourselves is it stable or not? So its stability is inferred through these through the Mager classification. But then there are so many number of subtypes, again, that practicability is reduced, and the classification itself offers no clinical recommendation in correlation to the severity of injury. So I'm gonna go straight to the AO classification of thoracolumbar injuries, and this is the latest version, the the version of 2013, which is sort of a combination of the Mager and Dennis classification systems. Again, it tries to be as simple as possible, as descriptive as possible, but as we will see, it takes some other things also into account. We have 3 basic types: the compression, the destruction, and the translational type. But the AO classification V2 2013 also takes into account the neurological status of the patient and some patient-specific modifiers. Now, the A0 fractures are the fractures of the transverse processes or of the lamina without further implication. But the A1 to A4 type is the compression fracture of the anterior element without posterior ligamentous complex involvement. Again, we have 4 subtypes, and keep in mind that these vertebral body subdivisions will be used again for the description of the types B and C. So knowing these A1 to A4 types sort of provides also a lot of information for the other types. So we have the A1, which is the wedge compression fracture, the end plate without involvement of the posterior wall of the vertebral body. You can see it in the image, and you can see also the typical plain radiographs and the CT scans. This is the A1. Then we have the A2, which is a split fracture. We saw it in the Dennis classification. We saw it in the Magri classification. This is the A2, again, without involvement of the posterior vertebral wall. Then we have the incomplete burst fracture, which is a fracture with involvement of the posterior vertebral wall and spinal canal involving only one end plate. All right, it's still an A fracture. I remind you that these are all vertebral body fracture classifications. And last but not least, we have the complete burst fracture with involvement of the posterior vertebral wall and both end plates. Now, the B types, I'm going to go a little back and remind you here on this slide. The B types are basically distraction types. They include the seatbelt or the chance fractures. All right, and the B types are of two types. The transosseous band disruption, where the disruption basically rips breaks the bone itself, and the transligamentous band disruption, where we have a rupture of the intraspinous ligament complex. These two types can and usually are combined with vertebral body fractures, which are described separately. So you can have an A3B2 fracture. And then we have the B3 fracture, which is basically a hyperextension fracture with rupture through the intravertebral disc. And this is a fracture that we classically see in stiff spine, aka ankylosing spondylitis. The type C is identical to the last category of the Magri and Dennis classifications, which is the torsion and rotation fractures, displacement in any direction. Once again, the body fracture is described here separately. Now, the AO classification takes into consideration also the neurological status at the moment of admission, with N0 being patient neurologically intact and N4 having a complete spinal cord injury. And then it also adds two patient-specific clinical modifiers, the M1, which is the indeterminate posterior column injury, which means basically, all right, we don't have an MRI or we cannot evaluate posterior complex so well. So we don't know what is happening with that stability factor. And the M2 is the patient-specific comorbidities, which includes but not limited to ankylosing spondylitis, rheumatologic conditions, burns affecting the skin, and so on and so forth. All right, what is important for the AO classification is that it does infer a degree of severity without describing it as such, but also extrapolates clinical, I will not say recommendations, but I will say like pathfinders with A0 to A2 fractures usually being treated conservatively, and type B and type C fractures almost invariably being treated surgically. And then we have this gray zone of the A3 and A4 fractures, where you can treat either way, depending on the neurological deficit. I remind you that this is a classification system that takes the neurological deficit into account, the degree of kyphosis and the comminution. Having said that, it is to date the probably the best classification system we have. It takes all four factors into account. It addresses stability, thus giving a clinical path forward. It has a predictive validity, and there are quite a few reliability studies with this classification system. Now, the problem is probably a little bit the number of subtypes. Again, right, there are a few, not as much as the Dennis or the Magri classification, but there are a number of subtypes that can complicate things. It necessitates CT and quite likely also MRI to appropriately assess the posterior ligamentous complex. And then we have the gray zones that I mentioned earlier regarding the A3, A4, and 0M1 fractures, which means the A3 fractures. All right, these are here, the ones that I showed you before, the incomplete burst fractures, and the complete burst fractures when we don't know what the situation of the posterior complex is, and the patient is otherwise neurologically intact. All right. Now, what is the reality? Do we have an ideal classification system? The evolution of the classification system.
Could you speed up a little? We're a bit late.
Yes, this is the last slide actually. It means that we are not there yet, but most of surgeons use the AO and MACLI classification, and the rest are using other classification systems. So it's a process in the making for 90 years. Historically, all those systems we talked about are widely used, but not flawless. And one last slide, those systems are here to help us, but the clinical experience and the clinical scenario should not be outweighed by these classification systems to guide treatment. Thank you.